At the time, and really still, the situation remains the same. We'd gone through a lot of fiscal cutbacks. Beds were closed. Hospital stays were much shorter. We had to wait long wait times to get patients in to see specialists or get investigations done. And all of this tended to download a lot of pressure into the community resources, not just family docs, but public health and home care and the rehab services all started to create a lot more pressure in the community. Combining that with the chronic shortage of not just physicians, but also nurses and pharmacists and everybody else, it became quite an unsatisfactory environment to work in. And I was asked once why you started to do this. And I actually remember having talked about this with some of my colleagues, and we got together for a meeting to decide what to do. And everybody around the table said, you know, we are just spinning our wheels. We are working faster and harder, and we are actually, it just doesn't feel good because we're just not able to provide the care that we want to provide. And sometimes we don't even feel safe providing the care. And so something's got to change. And so this can't be worse than where we're at. And it was within that environment that we said, okay, let's take this on. Let's see what happens. And so some of those deficiencies then created what's called the tyranny of the urgent. And there's a fascinating paper. And the tyranny of the urgent, we all understand. Patients wait a long time for appointments. And then when they get there, I feel terrible when I know I make them wait at least half an hour, sometimes an hour, sometimes longer, and that's just not appropriate. But standing room only in the waiting room is it just drives you to the point where you just try to get by, just get one visit at a time. And when that happens, then the screening that we want to do, the chronic disease management that we want to do, is an afterthought. It's a luxury because we're just doing one episodic visit at a time. Teams, well, I can't slow down for that. That's just not going to happen because I've got so much going on. And so we also felt, even if we did, we don't have the community resources to refer into. We don't have resources for patients to learn how to take care of their own illnesses. So you end up on this wheel. There was a fascinating chronic disease management conference in Calgary in July during Stampede Week. It was an international conference, and we debated, should what we see in the world right now be called the tsunami of chronic disease or the epidemic of chronic disease? And we decided, no, we call it the Calgary Stampede of chronic disease. And certainly, the World Health Organization has recognized that the management of chronic disease is going to be the greatest challenge of the 21st century. And the data is clear. Conference Board of Canada actually came through with a report from Ontario stating that the rate of rise in healthcare spending will outstrip our GDP by 2020 and maybe sooner. And the only way we can really deal with this is by improving our productivity, by using the money we've got and becoming more productive and increasing our capacity to provide care. Health Council of Canada in December 2007 really told us what we already knew, that the Canadian health system is not healthy. That even though we know what we should be doing with our diabetics and our hypertensives, we're just not able to accomplish those kinds of things. Screening. We had an Alberta cervical screening program which infused a huge amount of money. And we managed to increase our provincial screening rate from 33% to 38%. In cervical screening. What's happening to the other 62% of women that are eligible for that? CMAJ just a few months ago reported that less than 10% of eligible Canadians are screened for colorectal cancer, probably the one most devastating cancer that we've got. Where are the rest of the people? Why aren't we able to provide them the care that they should get? Also in that same report, and actually another report from Health Council of Canada just came out last month talking about the situation in community and home care, stating that of all the 7 developing countries, we make our people wait the longest. We are second to the US, and then the UK, Australia, and New Zealand do much, much better than we do. And even though it says 25% of Canadians wait greater than 6 days, I'll show you how long that actually was in Tabor when we actually started to measure it. And you think to yourself, well, 6 days, that's not bad. We'll come back to that. So despite all our best efforts, using the model we use now traditionally, using the resources that we have available to us now, we have been ineffective in Canada at meeting target levels that we have all agreed in guidelines to be what we want to do. Despite focusing on wait times are getting worse. And we really don't have a lot of examples to look at, to say, okay, well, what's another way of doing this? Are there other interprofessional models? And are there other team-based care plans that we could look at, but they're not easy to find? Don Berwick, the CEO of the Institute of Healthcare Improvement, had a hand in writing this paper, Crossing the Quality Chasm. And he concludes that these quality problems are not just in Canada, these are international. They occur not because of a failure of goodwill. I think of all the things everyone in this room wants to do, it's to provide that high quality, the best quality of care that we can provide to our patients. So it's not a failure of goodwill or of knowledge or effort or even the resources that are there, but because of some fundamental shortcomings in the way care is organized. So, stepping back then to what we learned from when we tried this integration process in 2000 to 2004. And I quote Dr. Sam Short from Queen's. And he talks a lot about, don't confuse the means for the end. Let's think about what that really means, because it's what we do. So in our project, it was actually defined as a research project, and there were 3 things that we stated we were going to accomplish and measure. One of them was that we wanted a new governance structure, a co-management structure where the region and the physicians in Tabor would come together in one group and bring the resources to the table and start to coordinate and integrate those. And we recognized maybe we didn't need quite as many hospital beds, but we certainly needed more home care nurses. And so we were able to do a little shifting within our own community to try to meet those needs. We developed an alternative payment model, and in Alberta, that's not the way. Motherhood and apple pie means fee for service. And so to actually create a capitation-based alternative payment was quite a challenge, both politically and resource-wise. And then we also piloted a number of computerized records in an effort to try to be able to allow the health region staff and the hospital to communicate with the clinic staff. So those were our 3 objectives. And as you can imagine, all 3 really took a lot of work and effort. And at one particular meeting, we had what's called the Integration Committee. This was 24 people, and it represented all service providers, and it was a frontline committee, people from the hospital and from long-term care and home care and physicians. And I was presenting, it was about a year into the project, and I was presenting our successes in establishing these 3 criteria. And I looked out in the audience, and I just saw glazed eyes, blurred vision. And, you know, everybody was thinking, yeah, and what's next here? It was really quite a remarkable experience, and for some reason, and I don't know why, we started talking about Mrs. Smith. Everybody in the room knew Mrs. Smith. Mrs. Smith was known by the police and the social services and all healthcare providers. I went back after that meeting, counted up the number of times I had seen Mrs. Smith. It was 158 times in the preceding year. And because of that, we were providing her care, but we weren't meeting her needs at all. And in that meeting, we started to say, you know what? We've just put in place the infrastructure so that we could give Mrs. Smith care in a different way. We can now do things that we couldn't do before because we've got some change here that allows us to do that.